Hello, everyone. Welcome to another episode of Scoliosis Dialogues. My name is Jaysson Brooks. I'm a pediatric orthopedic surgeon located in Jackson, Mississippi, and I'm here with my colleague, Dr. Ryan Fitzgerald, who is practicing at Riley Children's Hospital in Indianapolis. We are so excited to interview two award winners at the 2020 SRS annual meeting, Dr. Patrick Cahill, as well as Dr. Saba Pasha. Thank you for joining us today.
Today, I have the honor of speaking with Pat Cahill about his Hibbs award-winning paper, a novel imaging study to quantify respiratory function in early onset scoliosis, introducing quantitative dynamic magnetic resonance imaging, or QD-MRI. Pat Cahill is a pediatric spine specialist at Children's Hospital of Philadelphia, and he's also the Robert M. Campbell Jr. Endowed Chair in Thoracic Insufficiency Syndrome. He's heavily involved in research and pushing the field of pediatric orthopedic spine surgery forward, as well as working with many surgery research interest groups. He's a chair in the PSSG, the core member of the HARM study group, as well as the chest wall and spine deformity study group. He's also on several editorial boards and heavily involved in SRS and POSNA. Pat, thanks so much for joining me this morning and taking time out of your schedule to talk with us about this exciting research.
Great. Thanks, Ryan. I'm really excited to be here and really excited to share more information about the research because, as you know, with SRS podium presentations, we only get 4 minutes. And so there's a lot more to the story that I'm glad I get to share with you today.
Fantastic. So before we kind of dive into the research, I wanted to ask you one quick question. Obviously, being at CHOP and having the privilege and honor of being the Robert M. Campbell Jr. Endowed Chair is a big deal. And obviously, it's a culmination of all the work that you've done throughout your career. But what's that like? What's it like to live in the legacy of Dr. Campbell?
Yeah, it's, as you said, a really amazing privilege and honor to be a part of that team and carrying on Dr. Campbell's legacy. My boss, Jack Flynn, is the best boss you could possibly imagine. I work at an institution where the culture of excellence permeates everything. There's nobody that's got the, quote, "it's not my job" attitude about anything. Everybody always wants to be the best they can be and better than they are now. I wake up before my alarm almost every day because I'm excited to get at it and get to work. So yes, I'm like a kid in a candy store, having trained at places where the culture is sort of the opposite. It's really amazing to be at a place where people are trying to do great things every day and trying to be better every day. So very grateful and aware that I am in a unique and special situation at the Children's Hospital of Philadelphia. Also really grateful and aware that Dr. Campbell has a unique and amazing legacy. And it's a responsibility and an honor to carry that on.
That's really fantastic. I mean, I work towards that sort of goal every day, and you know, it's a pleasure to know you too, and being able to work kind of nationally on things with you has been fantastic. So in that, you've won the Hibbs Award this last year for the SRS. Obviously, that's a huge accomplishment. Would you say that that's one of the bigger ones that you've had in your academic career?
Yeah, I would say it's probably in terms of academic awards, that's the biggest I've had. I was a co-author on a previous Hibbs Award that my partner Jack Flynn won, but this is the one where I was a senior author. But also more importantly, it represents something that's really important to me, that's getting recognition, something that I've been working on for a long time. It also represents my feelings about what's really important for the field that I'm studying, which is early onset scoliosis, and specifically measuring pulmonary outcomes and pulmonary function.
Fantastic. Well, like you said, 4 minutes isn't enough time, and I feel like the 15 to 20 that we have today isn't going to be either. So why don't we go ahead and dive into it a bit? So we already talked about the title of it, a novel imaging study to quantify respiratory function in early onset scoliosis, introducing QD-MRI. So the issue in the past has been that our gold standard really is using spirometry, and it requires active participation, and it's a summation of kind of the entire chest. So can you kind of walk us through this paper and what exactly QD-MRI is?
I would love to do that. Thanks for summarizing the shortcomings of what we have right now as well. So QD-MRI is a passive imaging study of the normal resting respiratory cycle. And so what that means is we don't require patients to take maximal efforts and do forced expiration and things like that that go on with spirometry. Also, we don't require them to have to create a seal around the spirometry and some of the other shortcomings that we have with spirometry. Those things require people to kind of have baseline level of intelligence and motor control that most kids under age 6 don't have. And then even some of the older kids that have intellectual impairments will never achieve. So we really, and Dr. Campbell recognized this, and I recognize this need, some sort of study that's passive, where we don't require any specific participation from our subjects or from our patients to measure respiratory function. I'll even take one step backwards and I'll say, why is it important to measure respiratory function? We're not lung doctors, we're bone doctors. And so why are we even caring about this? And I would say respiratory outcomes are the only outcome we should really be thinking about in early onset scoliosis, or at least the most important outcome. And actually, I heard Peter Sturm say that on a call the other night as well. If we're treating kids with scoliosis at a young age, it's not because we're treating a deformity that we're trying to improve the appearance of. We're really treating an impairment or an impending impairment that's going to have a detrimental effect on their function and potentially even their life expectancy. So the pulmonary impact of early onset spine deformity is deadly, and it's something that we need to be treating. But the problem is we don't know exactly how to measure it really well because of the shortcomings I just mentioned with spirometry.
No, that's a perfect setup and background, how you guys kind of ended up. So what's the answer? How do we look at this closer? And this is where QD MRI comes in, right?
Yeah.
And so basically, if I've got this right, it's 2,000 to 3,000 MRI slices during a free breathing cycle. So for the most part, this is for patients that are awake, supine, getting an MRI, just breathing normally. And then the QD MRI does a cinematic cycle during that respiratory cycle that allows us to kind of look at not only the lungs, but the chest wall and the diaphragm, and really the thorax as a ventilatory pump. Is that right?
Yeah, so close. I will say that that's the magic, and that's what it sounds like and seems like when it all comes together. But the background is that this has been going, we've been doing these types of investigations and working on this methodology for about 10 years. So what happens is while the child is laying there and just breathing, we get the MRI, and as you said, several thousand images are taken. But it can be at any point during the respiratory cycle. It just happens, randomly based on what the patient's respiratory rate is and when we obtain these slices and things like that. So the difficult part is taking these pictures, which are moments in time and not really being anchored to a cycle of respiration, and then assimilating them into a full inhalation and exhalational respiratory cycle. So there's a couple image processing points that have taken years to automate. First, you have to assign borders to the lungs and the heart and chest wall and diaphragm. Or when Dr. Campbell started doing this maybe 10 or 12 years ago, he was coordinating or collaborating with Jay Udapa, who's the senior endowed professor of medical image processing at the University of Pennsylvania, who's kind of the brains behind all this technology. What they had to do, it took them about 40 hours of human resources per study to kind of create this cinematic cycle. So they'd have to assign all the borders to the organs and different structures. And then they would have to sort of make some manual estimations about was that chest expanding, or was it more expanded or less expanded than the next cycle, and sort of collate and cycle these images together. But what they also worked on simultaneously was automating those processes, which is so we slowly went from 40 hours to 20 hours to 13 hours. And just within the last 18 months, we've gone to full automation of both of those processes, which is really exciting.
Yeah, that's a fantastic body of work to not only do that originally, but to automate it to the point where it's automatic. That's fantastic.
Yeah, so that's sort of the proprietary part of this technology, that they'll use that software to hopefully be able to transport this technology to other institutions and other places that have MRIs.
That's great. And I mean, so that was kind of part of this paper was introduction of this technology. But the other part of it was also you taking it the next step and how it relates to what we do. So for this paper, you looked at 30 patients that all had early onset scoliosis that were pretty evenly split between male and female, but also had neuromuscular conditions, congenital conditions, and syndromic conditions that led to chest wall deformity. And then you looked at their QD MRIs as well as other spirometry parameters before and after surgery, right?
Yeah, as much as we could for those that could do spirometry. But yes, we applied this to a group of patients that we treat, and we wanted to see if this technology was sensitive enough to pick up any response to treatment, and that treatment being surgery. Because again, it would be great to have a nice tool, but if it doesn't, the reason we originally got interested in using this tool was that we felt that there was a need to sort of justify what we were doing. Like, are we doing all these surgeries on really young kids with repetitive lengthenings and implant failures and infections for any measurable reason? So that was what kind of our first order of business to do clinically, was to see if there was a change or measurable change with this tool in those patients that we did surgery on. Yeah.
And so before, like, the clinical parameters as a surgeon doing this kind of surgery was frustrating, because you would do all of this and you wouldn't really see a big difference except for maybe in like the respiratory rate, which is I think what you showed in your paper. But basically these bilateral lung volumes at the end of expiration really did correlate strongly with functional residual capacity, right? So basically that's just confirming that, yes, this is working. This is allowing us to measure these things accurately.
Well, yeah. So the correlation between our end expiration volume and functional residual capacity just confirms that this can have some translation to spirometry. So spirometry, again, a lot of those measures are sort of maximal inspiration, maximal expiration, or a measure of how forceful you can maximize your breathing. And what we were measuring is just sort of the resting respiratory cycle. So it's not a one-to-one or intended to be a one-to-one with spirometry. And the only thing that probably should correlate was that end expiration volume that we get on the dynamic MRI and functional residual capacity. And fortunately, yes, there is a strong correlation between those two. So
that makes sense. And so with this study, you also have collected normative data. I know, I listened to your talk at SRS, and then I listened to the next version of it at Ikios, looking at kind of chest wall with hooks, which hopefully we'll have some time to talk about later. But with that normative data, then you were able to kind of compare and produce Z-scores. And really what you found in this was that there was a change from this surgery in these patients by 3.5 to 4.5 standard deviations, right? And so that's massively improved and really impressive. So where are you guys at kind of with the normative data component, and how did that all play into this process?
Yeah, thanks, Ryan. That's a great summary. So you're exactly right. The changes in response to surgery were more dramatic than we would have expected in terms of when we try to scale those and compare them to patients that are age matched and what we call normative. So it justifies what we do. It says that we do early onset scoliosis and we improve volumes or pulmonary function or some measure of respiratory function. So we achieved that goal. And then you're right. We had 40 or I guess 51 patients that we used to establish that normative data to kind of create those Z-scores. Right now, I'm pretty excited to report that we have an ongoing NIH-funded study to further augment that data set. So we're trying to enroll 300 to 500 normal subjects across a spectrum of ages and gender, and then be able to also use parameters like BMI, length, and others to create a much more specific set of expected values in dynamic lung MRI. So that's a huge amount of work. It's a lot of expense to get MRI scans on those kids. The things that go into it, we have to have every MRI scan read by a radiologist, which is expensive. We have to, have our image processing team confirm and correlate those issues. Some of the other exciting work that is going along with that NIH grant is we are also starting to look at not just the overall volume of the lungs, but the aeration of the lungs. So we can start to parse out relative areas of underventilation, such as atelectasis in its severest form. So not just looking at did we create more volume, but did we create more usable lung space, which I think is going to be important, because one of the criticisms that people have or concerns that we have is, are we intervening too late in some of our early onset scoliosis patients where we can just sort of expand the lung but not increase number of alveoli or surface area where gas exchange can occur. So that's a really important aspect of that NIH work. And then other important aspect of the NIH work is, can we start to use some of this information to guide surgical decision-making? If we see an area of relative underdevelopment, can we target surgeries to expand the chest in that area? Interestingly, we're also looking at trying to not just look at structures in the chest, but in the abdomen as well, because we think, particularly with lumbar deformity and pelvic obliquity, that abdominal organs are positioned in such a way that they can impair diaphragmatic motion and increase the work of respiration. So can we look at how well organs like the kidney and the spleen and the liver move before and after surgical intervention? And to do that, we have to kind of go through that same process and sort of assign values for some of these structures so that we can use machine learning to kind of create the edges and borders of those structures on our MRI scans. And then once we have that stuff in place, look at how well they move in various deformity states and various times during respiration. So a lot more work going on to further validate and refine this really exciting tool.
You mentioned the kidney index at your ichthyosis talk. In particular, the kidney tends not to move, huh? And so is that where the kidney index came from, and how is that process going?
Yeah, so what we found is with lumbar curves, the kidney tends to go from being oriented sort of vertically to transversely or horizontally. And it's also a lot of times right under the posterior diaphragm, with the concave side kidney being right under the posterior diaphragm. And sometimes we can see during the respiratory cycle that kidney moves up and down. We postulate that that's probably a little bit more work for the diaphragm to do because it's pushing the kidney out of the way. But in cases where it seems like the deformity's been long-standing, the kidney seems to be sort of stuck and doesn't move. And so the diaphragm doesn't really contract up and down in the area where it contacts the kidney as well. So we think that there are some abdominal components to decrease respiratory function as a result of spine deformity. And so it's some of the stuff that we've kind of intuitively thought about with the impact of pelvic obliquity, but now we're starting to get some qualitative imaging and hopefully eventually have some quantitative data to show that as well.
I kind of knew this was going to happen. We're already running out of time. Just so the whole audience, there's so many tangents I go on, but so the whole audience kind of gets a full sense of the paper, though. Let's just go through the conclusions of your Hibbs Award paper, kind of the highlight points, the key takeaways, and then if there's any more time, I'll ask you a couple more questions.
Yeah, so I think the main conclusion we hit on is that when we do early onset spine deformity, we have a positive impact on how much volume there is during the normal resting respiratory cycle. And we can, in a lot of cases, restore those volumes very close to what we would expect for a normal child of that age and size. So it reinforces what we've been doing in treating early onset spine deformity. And then the other big take home point is that we now are starting to develop a tool to measure and quantify pulmonary function in those patients that can't get spirometry or can't participate in spirometry. And even more, in a more exciting way, it gives us more regional information about what's going on with the respiratory cycle rather than just a summation of the concave and the convex lung or things like that. So really exciting stuff. I don't know if I mentioned it before, but the accuracy of the volumes that we can measure are to about 1/10 of a cc. So probably even more accurate in terms of volumetric measurements than spirometry. Yeah, really exciting stuff.
On the paper again, congratulations. I think it's a huge achievement. Obviously, a lot of people that have been working on this a long time to start getting to this point of being able to share it with the world. I think the most exciting part about this to me is that there's so much potential for this technology, not only in what we do with early onset scoliosis, but also extrapolating it to other disease processes, people that have restrictive lung disease or like our tweeners, our patients that maybe have idiopathic scoliosis and are kind of around that magical age of 10 years old. And can we, better define a time to go forward with final fusion? And, just there's so much potential in so many ways that this can go. So I just want to thank you for your work and congratulate you again on this award, as well as the RO1s that you guys have earned there.
Thanks a lot, Ryan.
Like I said, I could talk to you for hours about this. I think that we're kind of beyond our time. Thank you for taking some time out of your morning. And
happy to do it. Thanks a lot, Ryan.
All right, Pat.
I am honored to have as our guest Dr. Saba Pasha, and we are excited to hear more about your background as well as the research that won an award at this past annual meeting. So welcome.
Thank you, Jaysson. Thanks for having me. I'm really excited to be with you tonight and talk about my research and a little bit about myself.
Perfect. So Saba, please tell us where were you born? Kind of like what's your background? How did you get into doing the clinical research?
Sure. So I was born in Tehran, Iran. I grew up in Tehran. I did my undergrad in University of Tehran, and then I moved to Montreal, Canada to do my master's and PhD degrees. And during my PhD, I got to work with this awesome group in Montreal working on scoliosis and doing all this innovative research on scoliosis. And I got really interested in different aspects of it and how engineers can work with surgeons and help them to better understand and better treat the patients, bringing different tools to clinical care. And that's how I got really interested. And I decided to stay with scoliosis research for my professional life.
That's very interesting. It does seem like a non-traditional track where you're, not necessarily, I guess, working on some of the things that I'm sure some of your colleagues from your graduate school were working on, correct?
It is. I thought it was just an opportunity to learn about so many options and so many different avenues I could take in the medical field, being an engineer. So it was just interesting to get that introduction and then find my own path to continue that research.
Perfect. What did your parents do in Tehran, and then when you came over to Montreal?
Yeah, so my parents are still in Tehran, and they're both academics. My dad is a statistician, and my mom is a physicist. So
you got it naturally then.
Yeah, so yeah, that was really natural for us to go to science and engineering. That was just a natural path.
That's really interesting. That's great. And so when you aren't doing kind of groundbreaking research, what do you do kind of for hobbies, like your favorite pastime?
Right. So I love rock climbing. So if there's an opportunity to go outside, just go to the crag and climb some rocks, I would do that for sure. But I mean, in the last year, just being in this new condition, new world, I started picking up on biking and running as well.
Perfect. I guess the first lesson in rock climbing is how to fall or how not to fall. Like, I mean, like where do you start? Like is it small boulders and then you go from there?
Yeah, so that's actually really interesting. You need to know how to fall because that happens to all of us, and we need to know how to fall safely and make sure that we just don't lose everything while we're falling. So that's a really important lesson that when you start rock climbing, you need to practice it several times to make sure you're mastering your fall.
Oh my gosh, that sounds terrifying. Okay. Who would you say that your mentors in spine deformity research are? Like kind of who kind of helped you to see the light of all the things that could be discovered within spine deformity?
So I think I obviously learned a lot from my PhD team. Calorico Ban, who is a big name, I guess, in the spinal deformity from the engineering side of it, and also the physicians that I work with, Hubert Labert, Stéphane Parent, and Jean-Marc McTung. I think those people really showed me how we can incorporate engineering into medical research, especially in scoliosis. And I think later on, I learned a whole lot from Dr. René Castellan and his research on pathology of scoliosis. I think the way he's looking at the spine and deformity development is really eye-opening and was really interesting to me. And I also had the opportunity to work from so many great physicians and surgeons at Harvard Study Group. And that was how dedicated they are to research, despite their really busy clinic and all the surgeries they do, and how they're dedicated to innovative research was really interesting to me. And that got me really excited in working on a scoliotic spine.
That's perfect. So, that leads us into kind of the research that you do, and you received the John Moe Award for your project titled 3D Classification of Right Thoracic Scoliotic Spine by Means of Two-View Spinal Radiographs, a validation study. And for our listeners who can't actually see the abstract, it looks like you guys had already developed a 3D classification for right thoracic curves. And I guess my first question is, how did you develop the 3D classification? Is this based off the CT scan? Is this based off of EOS, or biplanar radiography? Like, how did you guys go about this?
Right. So I guess the standard of care for radiographic measurements in pediatric clinic are X-ray images. So we use those images by biplanar radiographs to create a 3D shape of the spine, and then using those three-dimensional curvature to classify patients in one lanky type based on some statistical model, hierarchical classification, and find what are the subtypes of a scoliotic in that one type that we are treating clinically. So if you have a right thoracic patient, what are different shape of the spine when we consider the sagittal and axial deformation? And that actually led us to this classification that, well, although we are doing this classification in three-dimensional, but when we look at the frontal and lateral view, we can actually identify some differences that a naked eye can also identify those, and use that as a way to 3D classify the patients, but only by using 2D images. Okay. And that hopefully kind of helps the surgeon to identify some of those differences that are not identifiable by only using the current classification system.
I know that your paper was mostly just on right thoracic curves. Do you guys expect this validation to expand to some of the other curve types that might be seen within the Lanky classification, or do you see this as a replacement for the Lanky classification?
So I am really excited to let you know that we have a paper that got accepted last month, maybe, that considers all Lanky types and then goes and develop this 3D classification, but then characterize those classifications based on AP and lateral images. So basically looking at all those two-view X-rays, we can now say, well, okay, in right thoracic patients, we have 5 subtypes that fall into right thoracic. In lumbar patients, we have 3 different types of patients. So there are some biomarkers in frontal and lateral view that you can pick, and then that helps that subclassify Lanky types based on those 3-dimensional characteristics.
So, for some people, it took them about 2 years to memorize, just the 6, Lanky types and, the lumbar modifiers. Do you think it's going to take people years to memorize, this 3D classification?
I guess the hope is really to use some sort of artificial intelligence and image processing to make that an automated tool that can do this classification just by having the X-ray images. So we can reduce the burden of learning all this process of 3D classification using those images. But as we are improving our image processing techniques, I'm hoping that that would be something that can be done automatically in the future.
Now, I like the sound of that. So, as soon as the X-ray pops up, it tells me not only what the classification is, but it tells me where to put my screws to fix it, right?
Exactly.
Perfect. So, we have a lot of non-surgeon members, even non-medical listeners who might be listening to this podcast. For the patient or the patient's parent who might be listening to this podcast episode, how is your research relevant to them?
So I think the focus of my research is to look at the spine in 3 dimensions, and other direction of that is to better understand what the pathology of scoliosis is, how a patient who doesn't have any other conditions start developing a scoliosis. So I think in the first line of research, looking at the spine, looking at a condition that is already 3-dimensional in 3 dimensions makes it much more clear to the physician to take care of that patient, and hopefully helps with surgical decision making. And even if it is a conservative treatment such as bracing, that would be helpful to them to identify those differences in the curvature of the spine. And I also think with better understanding of pathology of scoliosis, we can maybe prevent some of these curves from progressing to too much that even need the surgery, or just better understand, come up with some treatments that can prevent those type of curve development in a pediatric population.
Wow. So 3-dimensional imaging, artificial intelligence, this truly is the future of treatment of patients with scoliosis. So, Dr. Pasha, thank you so much for your time. Thank you so much for sharing your thoughts about your research, and congratulations on winning the John Moe Award for your research. And we look forward to all the things that you're going to be doing in the future.
Awesome. Thank you so much, Jaysson, for this opportunity to talk, and looking forward to all this awesome research to come out.
All right. You have a wonderful night.
Thank you. You too.
Thank you, everybody, for joining us for episode 6 of the Scoliosis Dialogues and SRS podcast. Again, thank you to my co-host, Dr. Jaysson Brooks. I'm Ryan Fitzgerald. We're looking forward to seeing you again in episode 7.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.